Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is HIV and OI, skin and mucous membranes, and the speaker is Dr. Rajiv Dey. Dr. Rajiv Dey, sir, is the Technical Specialist Public Health with iTech India. We welcome you, sir, for today's session and request you to start the session.
Thank you, Swetaji. Good afternoon, everybody. So this topic, skin and mucous membrane, is basically the chapter number 4.5 in National Guideline for HIV Care and Treatment 2021 by NACO. And it was taken long back as a part of National Distance Learning Seminar series by a different speaker. So today's discussion would be basically a recapitulation of that. Now, skin, as we know, is most frequently been affected by different conditions in HIV. In PLHIV, around 90% of them suffer from some sorts of skin condition. So it is very, very important for anybody who is working in the field of HIV to look for the signs and symptoms in the skin. Similarly, there are certain skin conditions which are also found in general population, which might point towards the possibility of having a HIV in that particular patient. So we need to look for the skin even in the general OPD setup. Now we'll be discussing.
So click on the slide and then.
In this topic under this introduction. Pardon?
Yeah, it's visible now, sir.
Okay. Now it will be covered under this heading in skin manifestation of staph or streptococcal infection, fungal infection, viral, then inflammatory conditions, cutaneous malignancies, and miscellaneous skin conditions in PLHIV. As we were discussing, that 90% of PLHIV develop skin, and around more than 1/3 to more than half of the CLHIV develop some sort of skin manifestation. This identification of certain skin condition can predict the presence of HIV. So, for example, bilaterally EPL herpes zoster infections or refractory can point to the possibility of having HIV in that particular patient. And the characteristics of these infections in PLHIV are that they are very much persisting, recurring, chronic, severe, and resistant, and they are frequent atypical presentation. So, for example, multidermatomal herpes zoster or that refractory fungal infections can point towards the possibility of HIV in a particular patient. Now, as we know, the different opportunistic infection occur with a different CD4 level. Let us investigate the manifestation, skin manifestation in PLHIV in terms of CD4 level. So the CD4 depending on the level of the immunosuppression, different skin conditions occur more frequently in a PLHIV. And the seroconversion itself has got an exanthema. So around 50% PLHIV develop this exanthema reaction in the seroconversion. And in early part of immune suppression, that is CD4 count of say more than 500, almost healthy individual, then we find tinea, psoriasis, seborrheic dermatitis, bullous impetigo, just like general population. Then with intermediate suppression of CD4 or immune suppression, that is 200 to 500 cells per cubic millimeter of CD4 count, we find bacterial folliculitis, pityriasis versicolor or tinea versicolor, worse molluscum contagiosum, herpes zoster, herpes simplex, and advanced immunosuppression with CD4 count of less than 200 cells per cubic millimeter, we find more frequently aquatic thiosis, papulofollicular eruptions, oral candidiasis, oral hairy leukoplakia, Kaposi sarcoma, and Norwegian scabies. Now, if we want to classify different skin manifestation in PLHIV, the groups would be infective conditions, that is either bacterial, viral, fungal, or parasitic, then inflammatory conditions, cutaneous malignancies, and other miscellaneous conditions. So infective causes of skin manifestation in PLHIV can be either bacterial or fungal. In bacterial, we have folliculitis, furunculosis, ecthyma, abscess, impetigo, bacillary angiomatosis, syphilis, cutaneous tuberculosis, and disease caused by atypical mycobacteria. And in fungal, we have dermatophytosis, candidiasis, penicillosis, cryptococcosis, histoplasmosis. And in viral, it is herpes zoster, simplex, oral hair leukoplakia, molluscum contagiosum, Condyloma acuminata, Verruca vulgaris, Verruca plana. And in arthropod, we have scabies, leishmaniasis, Demodex folliculitis. Inflammatory conditions, the common inflammatory conditions in PLHIV are xerosis or ichthyosis, psoriasis, seborrheic dermatitis, Ritter syndrome, eosinophilic folliculitis, and atopic dermatitis. Other cutaneous conditions like malignancies, Kaposi sarcoma, non-Hodgkin's lymphoma, and other miscellaneous, we have acute seroconversion illness, drug reactions, papillopruritic eruption. This papillopruritic eruption can also point towards a possible diagnosis of HIV in general OPD setup. So we should look for that whether we are in ART center or we are seeing some patient in the general OPD. Now, coming to the skin manifestation of staph, the most common presentation are folliculitis, ecthyma, or non-bullous impetigo, and is the most common bacterial cutaneous infection in PLHIV. And many times, these infections may precede the diagnosis of HIV. The bullous impetigo is basically a superficial blister that erodes and breaks down and leaving behind erosions or yellow crust. The management is basically gentle cleaning of the lesion with soap and water. And in severe cases, we can go for aminopenicillin or cephalosporin or fluoxetine or erythromycin. The staph can give rise to skin abscess or pyomyositis. Clinical manifestation of follicular lesions extend more deeply, forming abscesses, making the affected area fluctuant and warm. In this relation, we need to remember that in cold abscess in tuberculosis, everything is similar, but warmth will not be there. It will be a cold one. Now, this staph, rarely all follicles over a area of skin can get infected, forming a large violaceous plaque. These plaques may mimic Kaposi sarcoma, and rarely an abscess can involve the muscle or management is basically surgical drainage and care of the lesion. And along with that, we should use antibiotics like cephalosporins or fluoxetine or vancomycin in severe cases of sepsis. Now, staph can also give rise to furunculosis or folliculitis, which is a sepsis around hair follicles of trunk, groin, axilla, and face, or it can be a carbuncle that is cluster of furuncles with multiple openings because of invasion and necrosis of the subcutis. Management is again local lesion care and antibiotics, cephalosporin, fluoxetine for 10 days. Now, bacillary angiomatosis. It is caused by Bartonella hanseli and Bartonella quintana. Cutaneous lesions start with a small red papule that gradually expand into large papular or nodular or pedunculated lesions, and lesions are highly vascular, and the surface break are quite friable and bleeds very easily. Systemic findings can be fever, night sweat, weight loss, anemia, or it can also involve visceral, different viscera of the body, particularly liver and spleen. And diagnosis is by silver impregnation or by electron microscopy. And the treatment is erythromycin 500 milligram 4 times a day or doxycycline 100 milligram twice daily for more than 3 months. Alternatively, we can go for azithromycin 500 milligram once daily. Now, the mycobacterial disease might manifest in the form of scophlioderma, as in the picture on the left-hand side and also on the right-hand side. Usually, the affected area, the neck, below jaw areas are most commonly been affected. The mycobacterial manifestation, cutaneous manifestation can be lupus vulgaris, scophlioderma, tuberculosis verruca cutis are common in India and in Indian PLHIV. Mycobacterium commonly present as chronic sinus over informed lymph node, that is the scrofula, or chronic ulcerations can be there. Mycobacterium haemophilum rarely can present with cutaneous abscess or ulceration and tenosynovitis or arthritis. Treatment is as per the ATT according to national guideline. Now, syphilis can present as either primary syphilis with a painless indurated genital ulcer or chancre with inguinal lymphadenopathy, or in case of secondary syphilis, might present with a rash involving the palms and soles in a macular fashion. The treatment is benzathine penicillin, 2.4 million units, IM single dose. Follow up RPR at 6 months until it is negative. We should repeat this benzathine penicillin. Now, the primary syphilis on the left-hand side is the chancre, and which progress very rapidly. And on the right-hand side, it is the secondary syphilis, the cutaneous presentation on the palm and the sole. Now, in fungal infections, can be presented with candidiasis as a vivid red, slightly eroded and studded with tiny pustules at periphery. And is this hallmark of this rash is the satellite pustules extending out centrifugally from the eroded area, or it can be an oral candidiasis, which have learned earlier in the OI, general OI chapter, and is a white membrane covering the tongue, and with the tongue depressor, we can easily remove this, unlike other oral condition. And it can also infect nails, tissues around the fingernails as paronychia. And diagnosis of potassium hydroxide examination of scales taken from the active border or a satellite pustules. But in most of the cases, it is basically a clinical diagnosis. Treatment involves a topical antifungal drugs such as clotrimazole 1% or ketoconazole 2% cream, fluconazole 100 milligram orally once, and for children 3 to 6 milligram per kg per day for 10 days. Now, it is also caused by superficial fungus, tinea. It is caused by superficial fungus belonging to various genera of fungus found in soil, animal, and human. Manifestations are either tinea cruris in the groins, tinea corporis in the body, tinea manam in the hand, tinea pedis in the feet or in the leg, tinea capitis in the scalp, and psychosis burbi in the bearded area of the face, and onychomycosis, that is on the fungal nail infection. In CLHIV, tinea capitis can present with broken hair, resulting in non-scarring alopecia, scaling, and pustules. And in all these cases, we need to refer the patient to a dermatologist. Other fungal infection can be in the form of pityriaciform ovale and orbicularis and Malassezii furfur, which causes tinea versicolor, seborrheic dermatitis, and folliculitis. Colonization occur in the skull, flexures, and upper trunk, and diagnosis is mostly clinical, and confirmation can be done by KOH examination of the skin scraping. And treatment involves the use of selenium sulfide shampoo, topical imidazole cream, or oral itraconazole 200 milligram daily for 1 week. Now, coming to systemic or deep mycosis, it includes penicilliosis, cryptococcosis, histoplasmosis, sporotrichosis, aspergillosis, candidiasis, coccidiomycosis, and actinomycosis. Now, here, tularomycosis or penicilliosis many a time can mimic with the cryptococcal skin lesions, but the difference is that in tularomycosis, you will find central necrotic papule with umbilication on the face, on the skin of the face mostly, then trunk and on extremities. And cryptococcal skin lesions can also mimic molluscum, because there is some umbilication in the skin lesions, both in cryptococcal skin lesions and in molluscum contagiosum. So on the left-hand side, we find tularomycosis, that is the central necrosis with umbilication. And cryptococcal skin infection, we find almost like molluscum with central umbilication. And in histoplasmosis, that is in the right-hand side, we find polymorphic rashes and polymorphic papules or plaques with or without crust, and pustules or nodules. This can be presented, found in histoplasmosis cutaneous, but many a times these are also associated with the disseminated form. So where we will find other areas, or other areas may be involved, so for example, pulmonary or CNS. So we can diagnose from there using the standard diagnostic procedure. Now, in viral infection, we have human herpes virus 8 disease, that is Kaposi sarcoma associated herpes virus, and is associated with all form of Kaposi sarcoma, including classic, endemic, transplant-related, and AIDS-related, as well as rare neoplastic disorders like primary effusion lymphoma and solid organ variants, and the lymphoproliferative disorders like multicentric Castleman disease. Now, skin lesions are basically non-tender, hyperpigmented, violaceous, macular, or nodular skin lesions, and oral lesions are purplish, fleshy swelling on the roof of the mouth or on the gums. And lymphatic system is involved in the form of lymphadenopathy, and pulmonary system, once affected, it presents similar to pulmonary tuberculosis or PCP. And if the internal viscera are involved, then the patient may be asymptomatic or might manifest with the area of involvement, signs and symptoms of the area of involvement, like manifestation with shortness of breath in case of pulmonary involvement, painless rectal bleeding or melena, specific pulmonary and GI symptoms. Diagnosis is by cytologic and immunologic cell markers as well as histology. Now, this is the Kaposi sarcoma cutaneous variety. On the left-hand side, we can see the bluish papular lesions, and it can also affect the eyelids, as in the right-hand side. Now, in case of management of Kaposi, in case of mild to moderate Kaposi, we need to put the patient on ART as early as possible. If the patient is not on already ART, we should put him on an ART. And if the patient is already on ART but developing Kaposi sarcoma, then we need to ascertain that the patient is on effective antiretroviral therapy, that the patient is not failing. And if we find the patient is failing on a particular ART regimen, we need to switch the patient to either second line or third line antiretroviral as per the standard protocol. Now, advanced Kaposi sarcoma, that is visceral and or disseminated cutaneous disease, ART has to be started along with chemotherapy in consultation with the specialist. And liposomal doxorubicin is preferred first-line chemotherapy in such cases. And here, one important thing to remember is that we should avoid the use of corticosteroid in Kaposi sarcoma, both in the Kaposi sarcoma and Kaposi sarcoma involving IRIS, because of the potential for exacerbation of life-threatening diseases. Now, primary effusion lymphoma, the chemotherapy in consultation with specialist per ART, and as an adjunctive therapy, we can use oral valganciclovir or IV ganciclovir. Then multicentric Castleman's disease, all patients with MCD should receive ART in conjunction with the IV ganciclovir or oral valganciclovir, with or without high-dose zidovudine or rituximab, with or without prednisolone. For patients with concurrent Kaposi sarcoma and MCD, rituximab plus liposomal doxorubicin should be used. But we need to remember that here in all these cases, we need to refer the patient to the specialist, and consultation with them only we need to manage the cases. Now, herpes simplex virus disease can be either HSV1 or HSV2, the most common form, and 95% of the homosexual PLHIV, some form of herpes simplex viral infection is found, and it is most commonly the viral setting happens when the CD4 count goes below 200 cells per cubic millimeter, and in MSM, it is one of the most common cause of proctitis. The manifestation of non-mucosal herpes like keratitis, encephalitis, hepatitis, herpetic whitlow are almost like as observed in general population or HIV negative individual. Now, the different phases, either it can be a primary one, that is for the first time the patient has acquired the infection, or it can be a latent infection, that is the viral genome has got incorporated in the host cell but remains in an inactive form, or it can be a reactivation when the host immune system gets impaired. Now, herpes simplex virus disease can be either orolabial herpes or genital herpes. There are some similarities, some differences, like orolabial is caused by herpes simplex virus 1, while genital herpes is by HSV2. In orolabial, the oral mucosa involved and lip is involved, and in genital, the mucosa and skin of the genital region is involved. And the evolution of the skin lesion is similar in both the cases. First, there will be a papule, which will become a vesicle, then it will ulcerate and will also crust in both the two cases. Now, in orolabial herpes, it progresses rapidly, and the course of the illness is 5 to 10 days. In case of genital herpes, local pain and pruritus will be there, and inguinal lymphadenopathy will also be there. So on the left-hand side, we find orolabial herpes. These vesicles are very, very characteristics of this herpes infection, orolabial or genital. In both the cases, we can find these vesicles. Diagnosis can be done by PCR or viral culture, but mostly it is a clinical diagnosis. And the duration of management is 5 to 10 days of acyclovir treatment with 400 milligram thrice daily. And in case of children, it is 20 milligram per kg body weight. Up to a maximum of 400 milligram per dose can be given by mouth, and valacyclovir 1 gram orally thrice daily can also be given. And in case of genital lesion, the treatment regimen is almost same, 400 milligram thrice daily for 5 to 10 days. And treatment of severe mucocutaneous herpes simplex, acyclovir 5 milligram per kg, IV 8 hourly, and in children less than 12 years of age, 10 milligram per kg body weight up to 15 milligram per kg body weight per dose, IV 8 hourly for 21 days. And once the lesion once the lesion regresses, we can change this IV acyclovir into oral acyclovir. So these are the different doses of acyclovir in children and foscarnet dose in children. Now, in case of herpes zoster, it is caused by varicella zoster virus or herpes virus type 3, and it occurs around 5 to 15% of PLHIV. And the course of herpes zoster is more prolonged with a higher risk of scarring and post-herpetic neuralgia in cases of PLHIV. And rest stirred with head or trunk extend to the extremities and evolve through stages of macule, then papule, then vesicule, pustules, and crust. Pruritus, fever, headache, malaise, and anorexia would be the accompanying symptom. So these are the typical lesions of herpes zoster in a dermatomal fashion, as in the case of herpes zoster ophthalmicus. And it happens only when the nasociliary branch of the trigeminal nerve is involved. Then we find herpes zoster ophthalmicus. And in PLHIV, this dermatomal restriction of the lesion may not be there. It can be bilateral also, or it can be multidermatomal also, depending on the level of immunosuppression. Now, clinical diagnosis is very distinct, as we discussed earlier. Now, viral culture, direct fluorescent antigen testing test, etc., can be done for confirmation. There is no recommended prophylaxis, and treatment duration is 7 to 10 days with valacyclovir 1000 milligram TDS or famciclovir 500 milligram TDS or acyclovir 800 milligram 5 times a day. So when we are using acyclovir, it is 5 times a day, but valacyclovir or famciclovir, it is thrice a day for 7 to 10 days. Now, this can also affect the corneal epithelium and should be treated with systemic or topical antiherpetic medication. And for extensive cutaneous lesion or visceral involvement, we should always use IV acyclovir 10 milligram per kg 8 hourly until clinical improvement is evident. Then once the clinical improvement is there, we can switch to oral therapy of acyclovir 800 milligram 5 times a day to complete a 10 to 14 day course. Now, in case of moderate to severe disease, the IV dose in children is 10 milligram per kg per dose 8 hourly for 7 days for moderate to severe. And for milder cases, acyclovir 20 milligram per kg per dose orally every 6 hours for 7 days. In acyclovir resistant cases, foscarnet 120 milligram per kg per day IV in 3 divided doses for 7 days can be used. IV acyclovir with a dose of 10 milligram per kg per dose TTS for 7 to 14 days to be given in children with severe immunosuppression or trigeminal nerve involvement and multidermatomal zoster. Now coming to molluscum contagiosum, it is caused by the molluscum contagiosum virus, a DNA pox virus, and is spread through skin-to-skin contact, especially during sexual activity. And lesions, small flashy-colored or pink dome-shaped bumps that are shiny pearl-like papules or nodules and are around 2 to 10 millimeter in diameter with central umbilication. And it tend to proliferate with the CD4 count of less than 50 cells per cubic millimeter. Now, this molluscum contagiosum looks like this, as in the picture. So it mostly affects the face. And Diagnosis is usually clinical, and treatment is basically cryotherapy with liquid nitrogen or curettage or extracting lesions, and electrocautery can also be used to remove the lesion. Topical gel or cream in the podophyllin or trichloroacetic acid can be used. Tretinoin, tincture of iodine, silver nitrate, or phenol can also be applied directly to the lesion. Cimetidine can be used if the area becomes inflamed or itchy. And these lesions are extensive. In case of extensive molluscum contagiosum, we need to start ART as early as possible. Now, coming to oral hair leukoplakia, it affects around 20% of PLHIV, and it is exclusively found on the lateral margin of the tongue. It may be the first sign of development of AIDS in a PLHIV. There are white striations along the lateral margin of the tongue. It can be shaggy in appearance and may contain several ridges. It might resemble oral candidiasis, but it is very difficult to scrape off, unlike oral candidiasis. And usually patients are asymptomatic and discovered during a routine clinical examination. So this oral hairy leukoplakia looks something like this, as in the picture. So there are ridges also, and it is restricted to the lateral margin of the tongue. So diagnosis based on the clinical inspection scrape test is useful, and diagnosis is confirmed if Epstein-Barr virus is identified in oral lesion by electron microscopy. And treatment is usually, no treatment is required. However, tretinoin and podophyllin resin can be applied directly to the patches, and liquid nitrogen cryotherapy or other surgical and maneuvers can also be done. Then coming to inflammatory conditions, it can be either xerosis, that is increased dryness of the skin, and most prominently found on the lower legs, but it can be quite widespread, involving the whole of the body can also be there. Now, treatment is application of moisturizer, mild topical steroid in the form of 1% to 2.5% hydrocortisone or 0.025% triamcinolone can be used for dermatitis, and to cover all dry areas of the body with a moisturizing lotion or cream after bathing and at that time. Now, seborrheic dermatitis, it is a mild eruption usually affecting the scalp and central areas of the face, occasionally affects chest, particularly individuals with a lot of chest hair and the axilla and groin. One of the most common inflammatory dermatosis observed in CLHIV, around 83% of CLHIV, it is found. Now, it is basically poorly defined faint pink patches with mild to profuse fine, loose, waxy scales. And in CLHIV, it may present as erythematous scaly patches with an overlying greasy scale on the scalp, eyebrows, perinasal areas, chest, back, axilla, and groin. And treatment is mild topical steroid, as for example, 1% hydrocortisone, tar shampoos, and often twice daily application of topical imidazole cream, that is clotrimazole or ketoconazole. Now coming to malignancies. Non-Hodgkin's lymphoma, NHL, it is said to be most commonly found cancer in Indian PLHIV, and its prevalence is 4.3%. Prevalence is 4.3% higher than in the general population, and in cases 80% severe cases of NHL, we will find high lactate dehydrogenase (LDH), which is a marker of the prognosis, and the manifestation depend on the site involved. And in PLHIV, it has a high invasive behavior due to disease progression or immune suppression. Treatment is chemotherapy. Basically, CHOP regimen is given. That is cyclophosphamide, hydroxydonorubicin, then oncovin or vincristine sulfate, and prednisolone along with ART is the standard treatment of non-Hodgkin's lymphoma. So we need to refer the patient to the specialist. So in non-Hodgkin's lymphoma, it appears something like this, as in the picture, a nodular below the skin, bumpy areas. So this non-Hodgkin's lymphoma is 70 times more common in male PLHIV than in the general population, and it is 10 times more common in female PLHIV than in the general woman without any HIV infection. Now coming to miscellaneous skin conditions. drug reactions, which are was very common with nevirapine and all, but with the phasing out of nevirapine and other efavirenz, this drug rash has gone down. But we infrequently, though, we will be able to see this kind of reactions. So which might present as a macule, as in the extreme left, or it can be a papule. There is some raised areas, and macule is a flat lesion. There is no edges or no raised area is found in the macule, but in papule you will find a little bit of elevated areas. And then it can be a vesicle, or a pustule can also be there in advanced cases. And drug reactions most commonly occur in the first, second week of therapy, and are typically maculopapular or morbilliform rash. That is, the rash may blanch on pressure. Now, use of systemic corticosteroid in the treatment of PCP has substantially reduced the rate of drug eruptions from Septern or cotrimoxazole. Other drug-induced hypersensory reactions like articular reactions, exfoliative dermatitis, then erythroderma, fixed drug eruptions, erythema multiforme, and toxic epidermal necrolysis can also happen. Now, coming to this papulopruritic eruptions, this is very commonly found in advanced HIV diseases. And in many of the patient may be diagnosed from this also. We can indent for HIV 1 and 2 test based on the findings, and these are usually bilateral and are found in equally. I mean, bilaterally equal eruptions can be seen, which are itchy and are papular in form. So it is 11 to 46% is the prevalence in the PLHIV, and it can be the first marker for HIV infection. Presence as chronic bilaterally symmetrical pruritic papules and sterile pustules on the trunk and extremities. And differential diagnoses include follicular and non-follicular pruritic eruptions, including scabies, insect bites, prurigo nodularis, and eczematous eruptions. Treatment is topical steroid, emollients, and oral antihistamines. Use of antibiotics can be given in case of secondary infections. Now, acute HIV exanthem and enanthem. Frequency of the rash is 50% of the PLHIV present with, and the rash may be eczematous, that is a generalized rash would be, or it can be pityriasis rosea like over the upper trunk and proximally, and may involve palm and sole. There are associated systematic features like fever, malaise, myalgia, arthralgia, and pharyngitis. Or it can also present as an enanthem, that is oral erythema or superficial erosions may be present in the pharynx and in the mouth. Dysphagia or retrosternal pain due to oral and esophageal ulceration may also be there. So we are concluding. In case of any question, you can ask me.
Thank you so much, sir, for facilitating this session. Sorry to the participants. I wasn't aware that we have the Yatra day today. I'm really sorry to have organized the session today. Any questions on the topic? Please feel free to unmute your mic, or you can also type in the chat box. So I don't think there are any questions. The next session will be held on Friday, that's 23rd of June. All the participants are requested to quickly attempt the feedback poll. There are 4 questions in all. Please scroll through all the 4 questions. Requesting all the participants to please attempt the feedback poll. The questions are visible on your screen. Dr. Rajiv sir, thank you so much for facilitating this session. Thank you to all the participants for patient listening. We'll end the session now.